So still, please do bear with me as I go through this, because this is based on what I'm looking at for my PhD. And just to put it into context, I'm a nurse by professional background, and I've spent the last 20 years working in cancer care. But I've been developing an interest in particularly people who identify as women and lesbian and their experience of cancer, primarily because of experiences that I've had in practice. And I recognise John has already this morning spoken about some of his experiences in practice, but really kind of reflecting on how colleagues have approached care of people that they see as different to them, and some of the discussions had in handover rooms, coffee breaks and things like that, and really starting to think, well, what's actually going on there, and how is that being kind of operationalised, I suppose, in a nursing sense. So what I'm going to hopefully talk to you about this afternoon is work based on a literature review that I've done, that I'm looking at publishing at the moment, that's looked at the existing literature that's out there around the lesbian experience of cancer. And then starting to think about queering the narratives of cancer that exist at the moment. And just give you some examples of that are published within cultural studies and social studies, but haven't yet made it into the healthcare literature. And that's one of the things that I'm quite keen on looking at, how we can work more interprofessionally, interdisciplinary, and see whether or not we can get some incredibly powerful work to actually cross over into nursing context, so that we can, sounds very grand, but make a difference on a day-to-day basis. So I've got a paper I'm going to read. I'm not used to doing it this way, but again, please bear with me. So, cancer is a highly feared, stigmatised and often misunderstood illness that is one of the leading causes of mortality in the world. And cancer is straight, or at least that could be the legitimate conclusion to draw from the extensive cancer-focused biomedical health and nursing literature. Although recognised as an area of health disparity, studies examining cancer from a queer perspective are still very few and far between. As a result, there is a lack of inclusivity, and the pervading assumptions within health and social care literature are ones of heterosexuality and heteronormativity. Furthermore, within the biomedical paradigm, being definable and countable is obligatory. The literature is awash with attempts to define a person in terms of their sexuality and sexual orientation, or laments the lack of a standard definition, as this would make their job so much easier. Stating, for example, if we can count you, we can determine whether or not this is a real problem, whatever that means. However, despite this desire to count, no national cancer registries routinely ask for people to identify their sexuality or sexual orientation, despite many calls for such information to be collected. And empirical studies examining cancer, for the most part, do not collect demographic information on sexuality or sexual identity. Even when studies do attempt to be inclusive, they only recruit one or two non-heterosexual participants, resulting in a heterosexual bias and a loss of a distinctly queer voice within the milieu. What the small body of evidence does show us, however, is that there's yet insufficient evidence or information to ascertain risks, incidence and impact of cancer on the queer community. A possible consequence of this omission is a lack of voice and a continued invisibility. Hopefully this talk presents work in progress that is attempting to introduce a queer voice into what is otherwise a familiar cancer narrative in order to disrupt that. Through examining cancer from a lesbian perspective, this talk will first examine the biomedical and health literature examining the so-called known risks of cancer and explore the desire of researchers to problematise and pathologise lesbian experience. It will then continue to consider the accepted cancer narrative and how this acts as a tool to ensure what Siegel and Bryson and Stacey called biographical compliance. Lastly, I hope to leave us with a little bit of a challenge regarding visibility and collaboration. So, there have been attempts within the health literature to examine cancer in women who identify as lesbian or gay, bisexual or queer. In a recent review of empirical research, 45 studies were identified where lesbian and bisexual women's risks, incidence, treatment choices and experiences of cancer and cancer care was taken as the primary focus. However, despite an estimated 159,000 women in the UK being diagnosed with over 200 different types of cancer each year, these studies only focus on cancers defined as women's cancers. i.e. breast cancer, and much less frequently reproductive cancers. To date, there has been no examination of risk, incidence or experiences of other common and equally deadly cancers such as lung, gastrointestinal, skin or haematological cancers. This despite even given the apparently higher incidence of key risk factors related to in lesbian and bisexual women, for example, obesity and smoking. For me, what this does is actually perpetuate the assumption that all women are primarily interested in their sexual attractiveness, breasts as sexual organs, for example, and whether they can reproduce. There appear to be major health issues of significant concern. For lesbian and bisexual women, smoking and alcohol consumption rates appear to be higher than for the general population. And within the US, there is an increase in obesity, although interestingly, they haven't found that in the UK. Wallace et al. In 2011 highlighted higher rates of serious chronic physical and mental health conditions for older lesbian and bisexual women, and a higher use of mental health services than in comparable heterosexual populations. Fredrickson and Goldson et al. Found that for older LGBT participants, there was a lifetime of victimisation, financial concern, reduced physical activity, all accounting for poor general health, disability and depression. Fish and Booley contend that lesbian-specific healthcare remains invisible and that lesbian healthcare differs in significant ways to heterosexual women in regards to behaviour, risks and experiences. Yet the construct of women's health is based on heteronormative discourse and assumptions of marriage and children, and where lesbian and bisexual women are seen as a homogenous group. Additionally, Fish contends that lesbian experience of sexism and heterosexism within healthcare are different to the experiences of heterosexual women. Lesbians have highlighted their experiences of hostility, fear, heterosexism, homophobia when seeking care, and amongst healthcare professionals, there is a lack of knowledge and embarrassment over lesbian and bisexual issues. And quite interestingly this morning, I don't know whether you've seen, Stonewall have just published a big study looking at attitudes of healthcare professionals to LGBTIQ people and highlighting exactly that there's a lack of knowledge and understanding. So lesbians therefore face a paradox when accessing healthcare services. Disclosure of their sexual minority status places them at risk of homophobia or poor care. Alternatively, not disclosing their sexuality potentially leads to heterosexism and care that is not responsive to their individual need. Furthermore, lesbians with cancer face making this choice at every interaction with a new healthcare professional, and that's a very frequent occurrence within cancer care, at a time when they are confronting life-changing health decisions. As I mentioned earlier, there are no registries that look specifically at LGBT identified people and cancer incidents, but based on extrapolation from other studies and self-reporting, figures in the US appear to suggest that lesbians are at greater risk of breast and ovarian cancer, primarily thought to be due to a reduced accumulation of pregnancy-acquired protective factors, lifestyle choices such as screening, uptake and obesity, although lifestyle choice obesity I would argue against, but I don't have a choice. A consequence of this rather prejudicial belief is that being a lesbian actually puts you at risk of cancer, which I'll discuss later, rather than the coexistence of life choices and risk factors such as nulliparity, which are not unique to lesbians, that increase the risk of these cancers. Additionally, other risk factors such as first menarche and age of menopause are no different in a lesbian and heterosexual populations. And it's still unclear whether any of these concentrations of risk factors actually results in a detectably higher rate of breast cancer. Despite this apparent increased risk, the National Lesbian and Healthcare Survey examined breast cancer risk perceptions, finding the majority of lesbians believed that their risk of breast cancer was the same as the heterosexual population. So that message isn't getting out there if that message is indeed truthful. Another study examining lesbian knowledge of human papillomavirus and cervical cancer risk found that 30% of participants did not know or did not believe that HPV could be spread by female-to-female sexual contact, and a further 29% did not identify HPV as a cause of cervical cancer. This lack of awareness of female-to-female HPV transmission is also replicated in studies examining healthcare professionals' knowledge, resulting in inaccurate advice and service provision. Again, raising questions as to the visibility and efficacy of public health campaigns and healthcare professional education. And I say that as a healthcare educator. Although tentative evidence for an increased risk for breast cancer and gynecological cancer appear to be available, there is no such evidence for other cancers. For example, as I mentioned, the prevalence of smoking appears to be higher in a lesbian and bisexual population. However, we don't know how that affects the risk factors again for lung cancer, head and neck cancer, renal cancer. Obesity increases the risk for colorectal cancer. Alcohol use increases the risk for gastrointestinal cancer. Yet again, we don't have any information as healthcare professionals as to the impact of that. Lesbian identified women are more often likely to report a perceived sexuality bias in the healthcare provider and fear of discrimination as key barriers to screening. In a large UK study, Fish and Anthony found that only 55% of lesbians attended for a regular pap smear. Barriers to obtaining mammograms were similar to those expressed to a presumed heterosexual group and include things like system factors and life demands. However, they also stated poor past experiences, homophobia, racism, and mistrust of the medical profession. Healthcare professionals seem determined to problematise and pathologise lesbian experiences within the context of cancer. Various studies have attempted to show that being a sexual minority woman with breast cancer puts you at higher risk of psychological trauma. However, this hypothesis doesn't seem to be supported by their evidence. McGregor et al., for example, examined the impact of internalised homophobia on women diagnosed with early breast cancer, concluding that lower self-esteem leads to internalised homophobia by way of elevated stress. However, with the exception of screening, they failed to link their findings to cancer. Faubert found no difference in mood and ability to deal with conflict. Lesbians experienced less body image and sexual activity disturbances and felt more supported by their partners, who rated highly on giving love and support as well as practical assistance. In Boehmer, lesbians were more likely to perceive greater levels of social support and coping and have lower levels of distress. And I've obviously taken on board with that whether or not their way of measuring those different concepts can be critiqued, but obviously working with what we've got at the moment. Ironically, however, lesbians in sport groups express significantly more cognitive avoidance, coping and distress. So the systems that are set up in order to support women were actually adding to distress around the cancer diagnosis rather than being helpful. So Jabson et al. Could not identify a significant relationship between sexual orientation and quality of life in breast cancer survivors, proposing that participants may have developed resilience due to chronic minority stress, which in turn facilitated coping with breast cancer. Arena and Boehmer compared the rates of anxiety and depression between heterosexual and sexual minority women survivors, finding no difference between them. In a further study, Boehmer attempted to determine the differences between lesbian and bisexual survivors' adjustment, finding sexual identity had no significant relationship with physical and mental health. They did, however, confirm McGregor's findings that internalised homophobia led to greater distress among lesbians, and supporting their earlier work, found partnered survivors fared better compared to single women. So these studies have assumed that being a sexual minority woman with breast cancer would automatically result in mental health problems. However, they have not first tried to develop an understanding of the meaning of cancer for their participants, and furthermore don't go on to prove their hypotheses. Interestingly, however, resilience does seem to play a role in this. Sexual minority women tend to undertake preparatory work early in the healthcare relationship to gauge whether their care environment is safe to disclose their status. This is quite interesting from a UK perspective because women or patients per se aren't necessarily given a choice as to the healthcare provider that they seek. So I know one of our colleagues mentioned earlier about you're given a GP and that's the person you go to. And then you're referred on to a consultant for specialist care. And I know that's different in some of the other countries, US for example. However, the absence of a response or disclosure of a negative reaction is seen as ignorance or discrimination. In addition, providers who also identify as lesbian with good medical reputations are in high demand. But interestingly, in the study by Sindling, it was found that actually the competence around the medical issues was seen as far more important to their participants, as opposed to the preferred sexual identity of their healthcare provider. However, 100% of healthcare professionals in the Boehmer case study failed to actively inquire about their client's sexual orientation, relying instead on the client to disclose this information. Sindling reported that lesbian identity and social context was ignored or dismissed within healthcare, and there was a lack of lesbian-positive psychosocial support. Fish, in a UK study, described situations where participants faced heterosexism from healthcare professionals, which resulted in discomfort and on occasion conflict, and a lack of continuity of care, where seeing a different doctor at each appointment meant having to come out to each new healthcare professional at each new consultation. There is evidence to suggest that lesbian women with breast cancer are better supported with their partners, and by their partners, I mentioned that before, than their heterosexual counterparts. Women also discuss tensions within their families of origin due to their sexuality and reliance on family of choice for support. Barnoff et al.'s participants expressed the desire to connect with other lesbians. However, there were barriers to participation in support groups for lesbians and their partners due to a lack of perceived acceptance and an overemphasis on breasts as objects of male sexual desire and being a lone woman in a partner support group. The role of the wider lesbian community is less clear. Barnhoff et al. Highlights the lesbian advantage, where women are especially empathetic, participants felt understood, and support was provided, was especially competent and well organised. They also discussed the lesbian chart, and I don't know if any of you are fans of the L word, but this idea of interconnected lesbian community that the people in the study refer to as the chart, and that in an urban setting, a diagnosis of cancer resulted in a community response. However, that wasn't replicated in a more rural setting. However, the opposite to this was isolation and disconnection. Some women spoke of the support network that was good at logistics but lacked empathy. There was a fear associated with cancer within the community and a personal fear forming new relationships, all of which happened against a backdrop of homophobic and heterosexist care. So for me, again, that's kind of replicating the stigmatisation that occurs around a cancer diagnosis within cancer itself, rather than looking at specific groups. So in Boehmer and White, an important discussion arose. Sexual minority women discussed breast cancer as a woman's issue, not a lesbian one, where breast cancer was aligned with being a woman and not their sexual identity. However, once they established the primacy of being a woman, they discussed how they managed their sexual identity in the context of breast cancer. Some participants highlighted living as a sexual minority woman in a heteronormative society had given them confidence to ensure their status did not become an issue, whilst others suggested that they were better off than heterosexual women, as physical appearance was less important to themselves and their female partners. They were protected from social expectations, for example, hair loss and weight gain, and had partners who could empathise. The placing of being a woman ahead of being a lesbian needs to be considered by examining the intersections of queer and feminism within, I believe, a cancer space. These issues of gender and sexuality have been seen as oppositional in terms of the theoretical discourse. However, there is room, obviously, to work within that. So what is an accepted cancer narrative then? So Siegel and Bryson and Stacey argue that the purpose of existing breast cancer narratives has been to produce a state of biographical compliance. And this is where the story acts as a regulatory device, essentially informing women of their new normal and how they could subsequently react or should react and behave, and perpetuating a state of ignorance about breast cancer. Furthermore, illness narratives, and this is from Siegel, illness narratives not only document and catalogue experience, they also reflect and reinscribe a hierarchy of values for such experience. Humour is good, despair is bad, surviving is noble, dying by implication is not. The genre itself of illness narrative renders some accounts more familiar than others, more welcome, more permissible, and finally more speakable. Interestingly, in some of the data, there has been no difference by orientation found regarding breast cancer treatment choices. However, the choices offered, what is acceptable, what is desirable, is in part determined by the normative cancer narrative. And the narrative is acting as the police in this choice. Siegel argues that people do not fashion their narratives out of just the events in their lives. Narratives are structured using the available knowledge. So ignorance about cancer is maintained by rehearsal of these stories with standard plots and standard features. There is a prescriptive coda attached to these stories of be like me, and these stories operate to suppress and replace stories that do not conform. Siegel argues that much of what we are told about breast cancer is meant not simply to inform us, but to evaluate, govern and control. For example, consider the discourse surrounding being a lesbian contributing to a higher risk of cancer. Although authors are careful not to explicitly connect sexuality with a cause of cancer, the undercurrent contained within the literature subversively sends the message that being gay is bad for you. Barbara Einrich recounts her experience of attempting to share her cancer story with an online breast cancer support group following her diagnosis. She spoke about her anger and despair of debilitating treatments, insurance companies, environmental carcinogens, and sappy pink ribbons. All very unpink, and calling for action against industries that are at one end producing carcinogens known to cause cancer, and on the other end are profiting against the fight against cancer. The response, however, from the online community, rather than being supportive, was one of reproach for her bad attitude and pity for her inability to move beyond her negative attitude towards her cancer. Bryson and Stacey concur. The accepted narrative: eat healthily, not like lesbians because we're fat, have children, lesbians are less likely to have children or have them later in life, breastfeed, don't use HRT, don't be overweight, and experience the transformational nature of cancer diagnosis. And when this knowledge is fed to us through the repetition of the cancer patient narrative, the individual is compelled to make the right kind of choices. So it is no wonder then that these are replicated when treatment choices are made. Perversive messages include: have the reconstruction following the mastectomy, as this will make you look whole again, like a real woman. Wear the wig, as hair makes the woman. Attend the Look Good, Feel Better programme, as all women like to wear makeup and pamper themselves. And then we stick a pink ribbon on it. Siegel argues that celebrity... Oh, sorry, I'll leave that. Within the non-healthcare queer literature, there are numerous examples of queer women being offered and even cajoled into treatment choices that do not reflect their gender expression or self-defined sexuality. Audre Lorde, in her seminal book, The Cancer Journals, and I'm sure many of you have read that, describes how she was once told when walking into a cancer surgeon's office that she should wear her breast prosthetic as she was bad for morale without it. In response to this, she writes, "I refuse to have my scars hidden or trivialised behind lamb's wool or silicone gel. I refuse to be reduced in my own eyes or in the eyes of others from warrior to mere victim, simply because it might render me a fraction more acceptable or less dangerous. I refuse to hide my body simply because it might make a woman-phobic world more comfortable." Bryson, in her breathtaking examination of her own breast cancer diagnosis, offers us this as an experience she underwent. It came up again with my GP. She actually said to me, more or less, "Oh, I thought you might be interested in this breast prosthetic, Mary, because look, it's so great. Then when you're out going out or whatever, and playing ball, or whatever, then you know you can just be like one of the girls." And it's like, what about me? Don't you understand? I don't play ball, and I'm not one of the girls. So a diagnosis of breast cancer can feel like a dragging back into normativity and gender conformativity. Jane, in 2014, laments the fact that you can spend your whole life creating an identity different from the one assigned. Then cancer threatens to suck you under into the archetypal death doled out out by the feminine body. Quoting Sedgwick's iconic statement, which I had at the first slide, "Shit, now I really must be a woman." And it seems swearing is the theme of the day. An example of the mammary bringing her under the umbrella of a gendered disease. So, how do we then queer cancer? As mentioned before, some women have spoken about how manifestations of cancer treatment empowered them, freeing them to express an identity that would otherwise have not been acceptable within their social reality. So this was in the Sinding study, where women who were conforming to gender normalities within their workspace, actually having chemotherapy, which resulted in alopecia, allowed them to present as the butch woman they felt that they had always been and were until that point unable to express. Conversely, however, Jane considers that even though a shaven head and breastlessness is a completely conceivable choice for a queer woman, when read within a cancer lived experience, cancer supplants this use of baldness or flat-chestedness to express identity and places the woman firmly within the cancer narrative. The oncologist, for example, noting a lack of hair, makes a comment to her within a cancer framework, and where the oncologist could not distinguish what might have been at any other point in Jane's life an expression of a specific selfhood. However, breastlessness offers another space in which conformity and female body visibility can be explored. Topless yoga is what Jane offers us. "I used to have another body," she says, "that you couldn't look at, but now I have this body that you can. Because its breasts have been taken off, and in that place remains a flat space that is sort of coded male, but really is very different. And when I take my shirt off, you can see that. And anyway, why should males get to hoard masculinity and shirtlessness to themselves?" Flat Topper Pride is an organisation designated to exploring the intersections of cancer and gender expression. Through documented experiences of being confronted with sexist and heteronormative assumptions regarding the roles of breasts, pathologising the choices of women who choose to have bilateral mastectomy rather than reconstruction, and empowering positive images of post-mastectomy women, Flat Toppers provides a space in which new and exciting gender expressions can be enacted. Melanie Tester describes her fight, who's one of the founding members of Flat Toppers, describes her fight to be accepted but for a choice she made based on her own need for symmetry and being evaluated by a psychiatrist, that she talks of being evaluated by a psychiatrist to ensure she was mentally capable of making a decision to have a bilateral mastectomy as opposed to reconstruction. Yet women choosing reconstruction, she goes on to say, are never offered a psychiatrist appointment to see how they are feeling about their breast cancer before the surgeon would agree to perform the surgery. She states, "For me, beauty ideals and expectations related to the female body are a form of tyranny. I resent that in the face of a lethal disease, the conversations turn to hair and wigs, reconstruction and look good, feel good programs. I seek to bolster a new female paradigm. In this paradigm, unilateral flat and bilateral flat as a body type is known and acknowledged, both in the breast cancer culture as well as outside this community. Prosthesis under the skin or tucked into a breast pocket are perceived as an option, not a conclusion." However, Jane spoke about the empowering nature of going bare-chested in her yoga class, states that had she had a unilateral procedure, the act would have been unthinkable to her. So her body coding for male gave her a permissive space for action, but I wonder, what about the uncodable body by today's gender binary system? Is a one-breasted woman too much of a woman to be seen without a top on, but not woman enough to be seen without a prosthetic, thinking of Lord. So, what is clear from the literature review and considering lesbian cancer narratives is that there remains a vast number of unanswered questions about the experiences of lesbians with cancer. But specifically for me, cancers other than that of the breast and reproductive organs. It could be argued that there are queer feminist cancer narratives available which are political, non-conforming and anti-normative. However, in focusing on cancers deemed as women's cancers, we are positioning gender as the primary point of analysis. Breast cancer is a good place to start, but it must go further and we must explore queer narratives surrounding other cancers. For example, how is resilience, as discussed in LGBT health literature, operationalised in a stigmatised cancer like lung cancer? Or queer sexuality enacted when faced with an unconcealable change in appearance, for example, in a head and neck cancer? And this morning, your picture I thought was absolutely wonderful of the pirate, so as an example of a potentially unhidable situation. So I just want, I've mentioned so. For me, what's quite sad is that there are some amazing pieces of activism, artworks, books, articles, biographies that are disrupting the cancer narrative and queering the cancer narrative. However, these at the moment aren't being heard by the healthcare sector. And as I said already about the Stonewall, it was quite fortuitous that got published this morning because it really kind of strengthens my argument there. That these amazing pieces of work are not being seen by doctors, nurses, occupational therapists, social workers, etc. So for me, the challenge ahead is to ensure that these analyses and critiques are seen by people working in healthcare, who can then use their new insights to ensure that they are providing care that is more person-centred, that is thinking of the individual as central to what they're doing. How we do this, though, remains a big question for me. So, thank you very much.
Thanks very much, Paula. Fantastic presentation. Should we just take one quick question before we break for drinks and so on?
No, that's fine. Cool.
I'll ask a quick question, if you don't mind, Paula. Something that stems from a debate I had with Julie Fish at an event recently around, and it stems on from that fine question about what we do about it. And it's around this debate whether or not we should continue to go down the route of specific services for the community, for gay men, for lesbians, for trans people, or whether or not we should fight more for an integrated service that is inclusive for our needs. And I just wonder where you stand on that, or is there anything you've looked at that kind of supports one or the other?
Yeah, I think one of the things I didn't mention that I kind of skipped over because thinking of time, was that since I've started this project, the one question I keep being asked is, well, surely the experience isn't any different. Why would it be different? And this is coming from nurses that I've worked with for 20 years, etc. So I think that in itself speaks to the problem that is that if the nurses that are running the support groups aren't seeing the experience as any different, they're not enabling people within those groups to talk about their experience as being different. So I think there is maybe a two-pronged approach that we need to take, is in that we need to raise awareness within the healthcare professions to ensure that they do address issues around sexuality, which is very much leading on from what you were talking about this morning. But I also think, thinking about Sindling's work, etc., that there is a real space for LGBT specific, or even going more polarised, lesbian specific, bisexual specific, support, help, guidance, just so that people feel that they have a space in which they can share. And yes, online communities are fabulous, but that does suggest, you have to be IT savvy in order to be able to access those. And cancer predominantly occurs in people who are over 65. So by the very nature of that, they're less likely to be IT savvy. So, and I think, there's been some recent work done on older LGBT people and about their experiences of healthcare that really do also, kind of resonate really with the cancer literature. So, does that answer your question?
Yeah, no, definitely. And on some of the data you presented saying that lesbians in some studies have been are more likely, or shown to be more likely to certain cancers. I meant to tell you this before when we were supposed to meet for coffee, that during the marriage referendum debate in Ireland, on one of our Irish language television programmes, there was a debate, and somebody who was anti-marriage used that as an argument for marriage. Because lesbians die younger, so they shouldn't be allowed to get married. So if they get married, they'd be left all these single, widowed lesbians. So I actually got Irish isn't my first spoken. I speak Irish, but I kind of rewind that. Did he actually just use that data the way I thought he did? So it's interesting.
Interesting commentary, really.